So good afternoon. I'm Jason Roberts, one of the newest faculty member for our GI division. Started in July, so I've had a chance to meet most of you, unless you've rotated with us. So I've asked to give a talk today and talk about pancreatitis and also give some talk a little bit about pseudocyst. Certainly a common disease. It seems like most of the patients are admitted to trauma surgery here. At least that's what I've kind of noticed. So I don't know how much you guys get exposed to it in general medicine on the floor, but perhaps in the ICU you'll see it. So the title here, Acute Pancreatitis, Medical or Surgical Disease, I only say that to just provoke you and make you think about it. And hopefully by the end of the talk you'll realize that this really is a medical disease and that as an internist, you're the primary player in trying to help your patients throughout their hospitalization. But before we get started, we have to start with a quote, of course, and I like this one. It's simple. There's 3 rules to life, and number 1, you got to eat when you can, sleep when you can, and finally, don't screw with the pancreas. So I think that's pretty good common sense, said by some surgeon. The first and second point are good for your well-being, and the third one's good for both you and your patient. And then this is a picture that is personally disturbing. This is taken an aerial photograph off of the beach where my wife grew up, and this is where we go back and visit. And so we're often swimming in those waters and not sure what's lurking off maybe 50 yards from us, and there's imminent danger. But thankfully, shark attacks are rare. So this is kind of like pancreatitis. There's a lot of potential danger there and harm, but thankfully, in most cases, people get through acute pancreatitis without much of a problem. So this is just I like the cartoon because it gives us an idea of what's going on in the pancreas. If you'll remember from medical school, you've got both an endocrine and exocrine function of the pancreas. And so here you see the endocrine components which release their contents into the blood supply. And then you have your ductal system, which is associated with your acinar cells, and that's where your proteolytic enzymes are produced and secreted into the pancreas juice. Most of the aqueous component of the juice is secreted through these duct cells, which are lining here, and often called the aqueous component, but it's mostly sodium bicarbonate. People with chronic pancreatitis, this is really the primary insult. You get decreased sodium bicarbonate production, which causes plugs and blockages in the bile in the pancreatic duct. And then, of course, the anatomy is such that there's a distal component of the common bile duct that traverses the head of the pancreas and drains into the ampulla of Vater along with the main pancreatic duct. And from histology, this is just another picture showing you the acinar units here with the nuclei, and then they're filled with these zymogen granules. You'll see a ductal cells lining up here around the duct, and you get an islet group here, and the vein and arteriole over here. This blows up the acinar unit here, and I wanted to show you a closer up picture because this is where all of the business happens when you're talking about acute pancreatitis. The acinar cells secrete their enzymes, which finally make it to the duct. Local inflammation develops here as the inciting event, and then that cascades, as we'll show later. This reminds you that trypsinogen is the main product in the zymogen granules that gets released, and through enterokinase located in the brush border of your small bowel gets activated to trypsin. You also get some autoactivation, and then some folks have this cathepsin B, which causes early activation within the pancreas. Trypsin, in turn, activates a lot of these other proteins that are also produced. So let's take a step back and let's talk about the big picture. Certainly acute pancreatitis is one of the most common GI disorders. It's estimated that it's 5 to 73 cases per 100,000 people. It's a wide estimate, but it depends on what study you look at. It certainly contributes to the healthcare cost, about $2.5 billion in 2009. It's the most common GI discharge diagnosis, not the most common GI disease, but at least for hospitalization's sake, one of the most common discharge diagnoses. And despite an increasing incidence, the mortality is low or going down, and that really owes to the improvements we have in our supportive care capabilities in the hospital. So how does it present? You guys know this as well as any. It's an inflammatory condition of the pancreas. It's typically associated with abdominal pain, usually epigastric, but not always. Sometimes left upper quadrant, and sometimes it's neither. Usually when the pain's present, it radiates to the back as it's a retroperitoneal structure, but that's not always true either. It can be associated with other symptoms, including nausea, vomiting, sometimes gastric outlet obstruction or ileus. It's also associated with pancreatic enzymes are elevated in the serum. We'll talk about that a bit more later. And if you image these folks, there's usually radiographic evidence of at least pancreatic edema, if not necrosis. Here's a fairly inclusive differential, although, or at least etiologies of acute pancreatitis. There's some more rare causes that may not be on here, but the lion's share is owed to alcohol and gallstones, okay, or so-called biliary pancreatitis. You get some folks that have hypertriglyceridemia, usually triglycerides over 1,000, or hypercalcemia, either primary or secondary hyperparathyroidism. Structural anomalies such as pancreas divisum, which is a congenital problem occurring in 7% to 15% of the population. There's debate about its contribution to acute pancreatitis, but it's considered by most folks to be a cause. Sphincter Vodi dysfunction is another debated cause. Then you have the folks with genetic predispositions to developing acute pancreatitis, and those include the serine protease 1 gene, the serine protease inhibitor Cazal type 1 or SPINK mutation, and cystic fibrosis. Medications, a long list of medications. Usually there are a few case reports of a medication in pancreatitis, but the causation is difficult to prove. But some that have the most literature are didanosine, azathioprine, and valproic acid, among some others, including some antibiotics. Trauma, certainly a noted cause, particularly in pediatrics that may get abdominal trauma and transect the pancreatic duct. You have some infectious causes, viruses like Coxsackie, bacterial, parasitic infections, pretty uncommon, not things that you're going to routinely see. Neither are vascular lesions such as vasculitis or thrombotic events. And then you have idiopathic, which after a thorough evaluation, you don't have a cause. You get lumped into idiopathic, which often is some genetic mutation, maybe sphincter Vodi dysfunction that's not been evaluated yet. So acute pancreatitis starts as some inciting event that happens locally there in the Acinar unit. In alcoholics, we think that they are primed, their pancreas is primed, so that they're sensitive to CCK activating the zymogen granules, which in turn leads to this upregulation of several transcription factors, also nuclear factor kappa B and activating protein 1. And gallstones, there's two mechanisms that are thought to contribute. One is the reflux of bile acids into the pancreatic duct can lead to early activation of trypsin and autodigestion. The other one is that you get a stone that's actually obstructing the ampulla, and you get pressurization of the pancreatic duct because of this obstruction, and that in turn leads to acute pancreatitis. We mentioned hypertriglyceridemia. You have increased free fatty acids, which are released by the lipase activity, and then it causes inflammation to the pancreatic capillaries. Genetic folks, the ones with the mutations, usually it involves some premature activation of zymogen granules. Again, it's a local inflammatory reaction or autodigestion. And then folks with cystic fibrosis or CFTR mutations, the thought is they have more of a viscous pancreatic juice, which may lead to increased intraductal pressures, and that's actually, there's some studies showing an increased association of pancreas divisum with CFTR mutations, so you have a pancreatic drainage through a minor papilla, a smaller orifice, associated with a more viscous fluid, and the two things together are felt to maybe contribute to their episode of pancreatitis. So once this inciting event occurs, on come the Four Horsemen, and number one, you get an intraacinar activation of proteolytic enzymes, which again leads to the autodigestion. This in turn leads to local vascular injury in the capillary bed. You get progressive ischemia to the organ, local edema, which in turn increases the oxidative stress. You then get recruitment of macrophages and granulocytes from this circulating blood supply, and you get release of the pro-inflammatory cytokines. And in people who are destined to get more severe pancreatitis, they're probably predisposed to developing a more robust SIRS response. Okay? So let's talk about how you diagnose somebody. There's actually some criteria. Sometimes it's difficult to diagnose pancreatitis, believe it or not, but you need two of these three criteria here. You need characteristic abdominal pain, so somebody who has, left lower quadrant pain may be difficult to entertain the idea of acute pancreatitis. So some sort of characteristic abdominal pain, or an elevation in your serum lipase or amylase greater than 3 times your upper limit of normal. That's important because every lab has different values for what's normal. I've seen as low as 7 for lipase at a VA I used to work at, and then as high as 393. So, oftentimes you'll get a lab printout from the referring hospital, and they'll have a lipase value but no upper limit of normal. So if their lipase is 400, but the upper limit of normal is 393, then that's really not pancreatitis. Whereas if it were 50, then yes, it meets criteria. And then also radiographic evidence of pancreatic inflammation. So you can see that not all three are required, at least 2 of the 3. Usually you're going to have pain as the presenting symptom that then gets evaluated with either labs or imaging. So pancreatitis comes in 2 flavors. There's the interstitial edematous and the necrotizing pancreatitis. So by far, interstitial edematous is the most common. It's characterized by enlargement of the pancreatic parenchyma from the edema. It's seen on imaging as a homogeneous enhancement because the vascular supply is intact. There's no necrosis. You get surrounding inflammation of the peripancreatic tissues, which often is manifested as this fat stranding. And you may develop peripancreatic fluid. We'll talk more about that later. These folks typically get better within a week. So like the sharks off the beach there, most people go swimming, don't get bitten. Most people with pancreatitis gets better, usually within a couple days to a week, without much harm. And then the bad player in all this is necrotizing pancreatitis. It involves necrosis of the parenchyma and the peripancreatic tissues, or either one by themselves. So you can actually get normal enhancement of the pancreatic parenchyma, but then get necrosis as peripancreatic tissues. I think I've got some pictures of that later. There's CT evidence of poor perfusion. Usually this evolves and becomes better seen over several days. So your first CT in the ER may not define pancreatic necrosis very well. And that's what this is showing. In 5 to 7 days, this well-demarcated area of hypoenhancement usually is better seen. And then it can go on to a variable course, and the area of necrosis can either remain solid or liquefy. It then may maintain sterility or become infected, and these collections may either be persistent or they could disappear and resolve completely. So let's talk about infected necrosis. It's a bad prognostic sign. Thankfully, it's rare, especially in the first week. So if you have a patient admitted with acute pancreatitis and you know that when they presented, that was when their pain began, you're catching it within the first week. Infection is pretty uncommon. It has a peak of around 2 to 4 weeks, and we'll kind of explain the mechanism behind that. It's associated with an increased morbidity and mortality, especially when associated with organ failure. So infected necrosis that develops sepsis and organ failure, these folks have really high risk of mortality, around 30% or higher. There's some data with carbapenems as being your antibiotic of choice, but it's not strong enough data to make that a clear recommendation. Infected necrosis is usually characterized by the appearance of extraluminal gas on imaging, or if you have performed a percutaneous FNA, you have positive gram staining culture, and we'll talk about whether or not we should routinely be recommending that. You suspect infected necrosis when you have a stable patient who then decompensates after they've been doing well for some time. And typically, again, this is seen after 7 days or more of being in the hospital, or at least the onset of acute pancreatitis. You'll sometimes see the term on imaging pancreatic abscess. This is an old term and should no longer be used, and so it can be confusing because when you think of an abscess, you think, well, you need bright lights and cold still, you need surgical debridement, drainage, et cetera, et cetera. That's very different than the management of a other or spontaneous intra-abdominal abscess. So that term is really fallen out of favor. So let's talk about complications of acute pancreatitis. If you have presence of organ failure, it is the definition of severe acute pancreatitis. Okay? And the organ systems that are involved typically are the respiratory, cardiovascular, and renal systems. We'll talk about that here in a minute. There are several scoring systems out there. The Marshall scoring system is a nice one because it's simple. It can be applied at the time of presentation and then again every day during their course, unlike some of the other systems like the Apache 2 and SOFA. So this is what the Marshall scoring system looks like, and here on the left side you see the organ systems lined up. The respiratory dysfunction is graded by the PO2 over the FiO2, and you can see as that ratio declines you get a higher score. In the renal system you look at the creatinine, and again higher creatinine is associated with a higher numeric value, and then the systolic blood pressure, either it's above 90, you get no points. It's less than 90, but fluid responsive, you get a point for that. The thought being that, easily a systolic pressure less than 90 that responds to a fluid bolus is not as severe as this person who has persistent hypotension despite aggressive fluid resuscitation. And then here you start looking at folks who have acidemia, which may be a sign of ischemic injury. And then if you have a score of 2 or higher for any of these organ systems, that's defined as organ failure. And of course, 2 or more organs failing is multi-system organ failure. We can talk about local complications. So we're going to see some pictures of these in a second, but they are specifically defined entities, and that's what the updated Atlanta classification schema focused on, is clearly defining these entities. So you start with acute peripancreatic fluid collections, pancreatic pseudocyst. When you have necrosis, you can have an acute necrotic collection that then can progress to walled-off necrosis. You can also have gastric outlet obstructions, either from a physical compression from maybe cyst or inflammation, or you can have just a gastric dysmotility associated with acute pancreatitis. You can also get portosplenic vein thromboses, which can then lead to other sequelae related to portal hypertension, such as ascites or splenomegaly. You can get intestinal necrosis, sometimes to the colon, sometimes small bowel. And then this is one that you'll see in the ICU occasionally, and particularly in mechanically ventilated patients, the intra-abdominal hypertension or compartment syndrome. And we'll talk about that also later. So you want to suspect these local complications if you have a patient that just continues to be painful, requiring high doses of narcotics despite good supportive care, or those that are doing well for several days and then they have a recurrence of their pain or they have clinical deterioration. We don't normally recommend following enzymes, but in this instance it might be helpful if you have enzymes that have normalized or have significantly dropped and then they start to rise again in the setting of someone doing more poorly. Clearly, if somebody develops organ failure, that's a sign of severe acute pancreatitis, but then you want to also look for the development of local complications. And folks that have fever and leukocytosis on admission are usually from just the acute pancreatitis, but those that develop it later on in the admission, you worry about development of complications. And what we do then is evaluate with a CT. And the CT is looking for specifically fluid collections, and it describes the location, the contents, whether it's solid, liquid, or gas, and then the wall thickness, whether it's a thin versus thick-walled collection, whether there's septations, so on and so forth. And it gives you a lot of other information about the rest of the peritoneum. So those are local. There's also systemic complications, and these are basically exacerbations of any of the patient's pre-existing comorbidities. So if they have CHF at baseline, COPD, chronic kidney disease, and these entities are worsened, then those are considered systemic complications. If you have de novo organ failure, then that's actually severe pancreatitis, not considered a a systemic complication. So again, I think it's not quite semantics. I think it's important to realize whether they have pre-existing disease and whether what you're seeing on admission is actually de novo insults from their severe acute pancreatitis. So it's a process and evolution when you have pancreatitis. So there's an early phase, which is what you're seeing in the first week of their hospitalization, and it's characterized by the host response. Okay, so what's going on clinically is being driven by this cytokine cascade and the patient's propensity to do this. Again, we talked earlier that folks more likely to develop SIRS are the ones who are going to lead to organ failure. You can develop transient organ failure. So at admission, if you have organ failure, you're going to diagnose your patient with severe acute pancreatitis. What you don't know yet is whether they're going to go on to have persistent organ failure or if they get better in 48 hours. And if they get better within 48 hours, then it's what's called moderately severe. Again, severity is determined by the presence of organ failure, and they can even have multi-organ failure. Late phase obviously follows the early phase and can last weeks to months depending on the patient's course. It's characterized by a persistence of systemic signs of inflammation or the presence of local complications. In this phase, you see, instead of the SIRS response, which is pro-inflammatory, you see the CARS response, which is anti-inflammatory. And it's thought that when you have a CARS predominant setting, that may play a role in secondary infection. Secondary infection usually is translocation of gut flora across the mucosal membranes because of multiple reasons, but including lack of enteral nutrition and stimulation of the gut, but also from the inflammatory response and the leaky permeability. Imaging defines the types of local complications. So again, your imaging plays a role in determining what kind of local complications are going on, and it helps direct management. So determining the severity, again, mild acute pancreatitis, the majority of cases you have no organ failure, you have no evidence of local complications or systemic complications. If you have transient organ failure, any of the local complications or systemic complications, you have moderately severe. And of course, any of the transient organ failure that remains persistent is called severe acute pancreatitis. These are important because it helps you risk stratify your patients and help determine where you should take care of them, whether it's in the ICU or maybe a progressive monitoring floor or just a general floor bed. Transient organ failure on admission, for instance, if they present with organ failure, you should treat them as severe acute pancreatitis, and you should treat them aggressively because of the risk of a prolonged SIRS response and progression to persistent organ failure. So we'll show you in a minute, early institution of intravenous fluid resuscitation decreases the risk of progression to SIRS. So there's better outcomes with fluids, and we all just think that fluids is second nature. It makes that's what we do. But that's why we do it. The mortality rate in severe acute pancreatitis is upwards to 50%, 36 to 50%, whereas the risk of death in mild acute pancreatitis is very low, almost zero. Infected necrosis along with organ failure, extremely high mortality. So imaging in the early phase, again, presence of local complications on CT, such as the peripancreatic fluid collections or acute necrotic collections, are not directly proportional to the degree of organ failure or the risk of infection. So even though you have those present, it doesn't tell you you're going to have bad organ failure or that you'll develop infection. It just means you have moderately severe pancreatitis. Necrosis may not be clearly defined in the early phase, so your admission CT may not help you, or 2 or 3 days later. Sometimes it's best seen 5 to 7 days later. Local complications do not require interventions beyond supportive care, so that's really the argument against doing a CT scan on admission if the diagnosis is clear and you're going to manage the patient with supportive care. The imaging really doesn't direct therapy at that point. So what are your modalities? You have CT, the standard of care for detecting necrosis and local complications. It also is good for looking at thromboses in your veins and pseudoaneurysms. MR shows improved detection of solid components. So whereas a CT may say there's a liquid cyst or a cyst, the MR tells you it's a mixed solid liquid cyst and will help you direct your therapy. It's equivalent at detecting necrosis even without contrast. So if you have renal failure, you don't want to give gadolinium. You can use the FS features of your your MR, and you can look at the fat, and the fat can help you determine necrosis. You can also assess biliary and pancreatic duct anatomy. You can look for leaks. You can look for stones. You can look for divisum and other things. EUS is also good. It helps characterize fluid collections similar to MR. It does offer you the opportunity to perform diagnostic and therapeutic interventions. The downside is it's probably less available than MR, and it's an invasive procedure requiring anesthesia. So let's talk about pancreatic and peripancreatic collections. Acute pancreatic fluid collections associated with interstitial edematous pancreatitis, okay? So when you see that, it doesn't necessarily mean something bad. It can just be part and parcel with developing pancreatic edema. If these persist for greater than 4 weeks and become organized with an encapsulated wall, we call them a pancreatic pseudocyst. So don't be tricked to believe in somebody who presents and a week later has a fluid collection. Don't call it a pancreatic pseudocyst. It's not until after 4 weeks. On the other hand, acute necrotic collections are analogous to your peripancreatic fluid collections, but they occur in the setting of necrosis. They can be solid or mixed with solid and fluid. And again, MR and ultrasound are useful in delineating the difference. CT is not as good. These collections, if persistent for greater than 4 weeks, can also become organized with an encapsulated wall and form this entity called walled-off necrosis. Okay, and that is rare in less than 4 weeks and similar to pancreatic pseudocysts. So this is a CT picture here, liver here, your left kidney, right kidney here, abdominal aorta and celiac artery coming off. This is your portal vein confluence and splenic vein. This is your pancreatic body here showing normal homogeneous enhancement. This is your gallbladder here. This dark area here is peripancreatic fluid. So that's peripancreatic fluid collection, normal enhancement of the pancreas. Give time, and those fluid collections can then develop into pseudocysts. So here you can see the wall of the cyst with what looks like fluid in, internal components. Here's a similar cyst. This is part of the pancreas here. This is the gastric lumen being compressed. You can see this bulge the cyst is causing. So, you don't do anything about a pseudocyst unless two things happen. It causes symptoms, either abdominal fullness or pain, or early satiety related to gastric outlet obstruction like this may cause, or they're infected. So just because it's there, you don't rush to do anything. You wait, most of them resolve on their own or get considerably smaller. What I see is a tendency to do something about these too soon. People want to stick tubes in them and it really doesn't help anything. This is just another picture. Stars showing you what's left of the pancreas, which looks normal with normal enhancement, and these large pseudocysts abutting each other. So this is a side-by-side comparison of the same patient over time. And on the left, this is closer to presentation. They have an acute necrotic collection, which is this heterogeneous area here around a normal enhancing pancreas. So you got normal pancreatic enhancement, you've got necrosis, and acute necrotic collection in the peripancreatic tissues. The same patient over time continues to have normal enhancement of the pancreatic body and tail, and then they get better organization of this acute necrotic collection and eventually develop a walled-off necrosis. This shows you in A, B, and C CT scans showing walled-off necrosis. Again, you see this is an internal septation, but you got a well-demarcated wall. Again, here, this is replacing almost all of the pancreas with hypoenhancing necrosis, and then you see this thick encapsulated wall here. And again, similarly, you see some fat sparing down here, walled-off necrosis all the way out to the tail of the pancreas where the splenic hilum is. Now, you look at these and you look at the dark areas and you think, well, it's just fluid. But this is an MRI scan showing you on T2 weighted images where fluid, like in the bile duct here, is bright white. You've got this necrotic collection which is partially fluid, but there's a lot of non-enhancing material in there indicating solid material necrosis. So Sometimes these will get labeled as a pseudocyst and they want to drain it, but when you look closer with EUS or MR, you'll see there's a lot of solid material in there and there's a risk of infection if you start to stick these. So let's talk about treatment. Mild acute pancreatitis, often self-limiting. Patients come to the ER, they're diagnosed, they give some fluids, they go home and they are on clear liquids for a day or two and they get better. Moderately severe can be variable, but usually requires a brief hospitalization and often supportive care, and they get better. Severe acute pancreatitis, by definition, is going to require hospitalization and treatment, monitoring of their ongoing organ failure. So some of the tenets of management, we talk about nutrition. Bowel rest is important, gastric distension from anything, water included, and any sort of caloric content, especially fats, can cause pancreatic stimulation and may potentiate the inflammatory reaction. Most patients experience clinical improvement and return to PO within less than 3 days. Early enteral nutrition via nasojejunal tube improves outcomes in severe pancreatitis and is superior to parenteral nutrition. So see a lot of TPN. We have really good dietitians here that can place NJ tubes. We can do it in endoscopy. It's really preferred in patients that you think are going to be in PO for more than 3 days, particularly those with severe acute pancreatitis. And it's been shown to improve outcomes. So I don't think I would jump to it in the first 24 hours, but you can wait and see how your patient responds. And if they're not getting better, try to get a tube in them. If you can't get an NJ tube, gastric feeds have been shown to be okay in patients that can tolerate it. Usually if they don't tolerate gastric feeds, it's because of dysmotility issues, gastric outlet obstruction, so on and so forth. So this idea that all gastric distension is bad is kind of been dogma, but we're slowly coming around to thinking, well, some nutrition is better than nothing, even if it means putting an NG tube in and giving it gastrically. There's a questionable role for immunonutrition. Dr. McClave can talk to you better than I can about that, and perhaps he has already, but immunonutrition, particularly glutamine and things like this, have been studied and have shown some benefits, but there's also some negative data, including harmful effects of that, so it's not recommended. What about IV fluids? So early resuscitation improves outcomes and reduces the risk of going on to SIRS, and that's clear. There's a question of what type of fluid. There's some data with Ringer's lactate being better than saline at reducing SIRS, but it's not dogma yet. There's this head of starch or hydroxyethyl starch, which is another expander that's been studied as well. So saline, Ringer's probably doesn't matter. Probably what's important is that you have goal-directed therapy, which means you're starting them at a rate based on their weight, and in 24 hours you're trying to get it in 1/2 to 4 liters. But your targets are improvements in the heart rate, improvements in their MAP, improvements in the urine output,
and improvements in their heme concentration. So if you watch and they have these things are abnormal at admission and they're getting better in 24 hours with your fluid management, then you're probably doing some good. So what about antibiotics? No proven benefit for prophylactic antibiotics. When I was in medical school, people were giving antibiotics for acute pancreatitis. It's not beneficial. Carbapenems may have some better tissue penetration, some better data, but again, it's still not dogmatic. Penicillins are okay, carbapenems are okay, some fluoroquinolones. You want to cover gut flora as the key here. There's a clear benefit if you suspect infected necrosis of given antibiotics, okay, because antibiotics can actually delay or prevent the need for interventions. You have improved outcomes when your interventions are able to be delayed beyond 3 to 4 weeks. So those fluid collections that are not well formed, and they then organize and have these well encapsulated walls after 3 to 4 weeks, your outcomes with intervention is much better. And antibiotics play a role in helping you get there. Tissue FNA for culture is not routinely recommended. If there's a strong enough clinical suspicion, you shouldn't wait or depend on this to direct your antibiotics. So get them on antibiotics if there's any concern. No need really to FNA for tissue and culture unless you suspect maybe secondary fungal infection. But again, I think adding an antifungal in patients who are not responding to antibiotics is totally reasonable. So also let's talk about abdominal compartment syndrome real quickly. Intra-abdominal hypertension is common in severe acute pancreatitis cases. It should be assessed in those patients, particularly the ones who are on mechanical ventilators in the unit. It's defined by an intra-abdominal pressure greater than 12 millimeters of mercury, and this is usually transduced to the bladder. Abdominal compartment syndrome is a sustained elevation of pressure of greater than 20 millimeters of mercury. It's really a bad prognostic sign with a horrible mortality associated with it. The treatment is luminal decompression from all ends, so NG suction from above, rectal tubes from below. Sometimes we'll do PEG tubes. Intravascular volume expansion to improve gut arterial flow. Peritoneal decompression. And this side, you want to err on giving too much volume. You have to dialyze them. You have to dialyze them. You have to give them diuretics. You do that, but you got to pump fluid in them. You need to do some sort of peritoneal decompression. That's a difficult bridge to jump over, but it's worth having the discussion. And you can do a laparotomy or a percutaneous drainage of any acidic fluid. They'll leave these patients open to expand the abdominal compartment space. So let's talk about interventions, and I think we're getting close to the last part of the talk. So early interventions for local complications such as the acute pancreatic fluid collection or acute necrotic collections with or without infections associated with worse outcomes. Okay, so even if it's infected, put them on antibiotics, give them time, supportive care, and if they're doing okay clinically, resist the urge to get radiology or surgery or us to go and put a needle in something. Infected necrosis requires antibiotics and can be followed conservatively. If those folks go on to develop sepsis or organ failure, then you're going to have to talk about doing something. But as long as these issues are well controlled, you can watch them and try to get them out further. Endoscopic debridement and drainage of walled-off necrosis is preferred to surgical necrosectomy. This is called the step-up approach. What they found is less morbidity and mortality associated with the endoscopic approach. And what step up means is sometimes that's all you have to do and you never result in a surgical necrosectomy. Or if you're able to partially treat the patient endoscopically first, they do better if you have to eventually do a surgical necrosectomy after that. So that's why it's called a step up approach. So this is an endoscopic picture of the antrum, and this is the pylorus right here. This is the anterior wall, this is the posterior wall, lesser curve, greater curve, and this is a bulge. This is from a large pseudocyst. This is an endoscopic ultrasound picture across the gastric wall. So this is the muscularis propria, this black line of the gastric wall. This is Doppler. So this is why, you can drain that endoscopically. You just stick a needle in the bulge and inject dye, and you can see the contrast on fluoro. But the reason I like EUS is because you see these perigastric collaterals here. So these are vessels on Doppler. You don't want to be sticking a needle in that. So this allows you to optimize your approach. This is the anechoic or fluid-filled cyst right here. This is the hyperechoic wall. You got a picture of it here. So this again is the hyperechoic needle coming through the gastric wall. Here's the tip. This is all artifact from the echo. And now you're in the cyst cavity. So now we have access. This is called EUS Guided Cystgastrostomy. You can do this with EUS guidance. You can do this with just endoscopic guidance where you see that bulge and stick. You can do it surgically where you make a laparotomy and you go through the stomach wall surgically. You see that posterior bulge and you open it up. So no matter how you approach it, it's all called a cystgastrostomy. You're creating a track through the stomach into the cyst. So after we get into the cyst with EUS guidance, we switch to fluoro, and this is the EUS scope. This is the transducer for the ultrasound here. This is after we've injected contrast into the cyst and we start to outline it on fluoro. Here we're putting a guide wire, which is a thin 0.025 inch guide wire. We're coiling it multiple times in the cyst to maintain access. And we'd already done this process once, and we placed a double pigtail plastic stent into the cyst and in the lumen of the stomach. Usually you'll place two, and that helps maintain the cystgastrostomy track and keep it open and allows the cyst contents to drain into the stomach. So these folks are therapeutically very gratifying because the cyst is under pressure. So you stick them and you dilate that track, a gush of fluid comes out, and when they wake up from anesthesia, they feel like a new person. So those are actually gratifying to do. Bless you. This is the picture of same case. These are the double pigtail stents, and this is the lumen view from the stomach. Okay, so that's what the stents look like. We leave them there for a few months. We re-image if the cyst is collapsed and is gone, and the patient doesn't have an active pancreatic duct leak. You can go back in a few months, pull these stents out, the hole closes off, and the patient's fine. So this is a case where the CT said there's a pseudocyst. Okay, well, let's go and drain it. And so we did. And what you're getting here is contrast, but it's heterogeneous filling. So this is fluid being replaced by contrast, and this is solid component. When more than a third of your cyst is, this is essentially a walled-off necrosis. It's not really a pseudocyst. So when you get more than a third of necrosis or necrotic material, your risk of infection is higher. So you don't just stick stents in it and leave. You have to keep those folks on antibiotics. You may leave a nasocystic drain in here to lavage and break this up over 24 hours in the hospital. And then your next step is to go back in and do debridement of this. And if this works, this is endoscopic debridement. So we've come back, and after a couple of weeks, we pulled the stents out, and we've actually placed the therapeutic scope through the cystgastrostomy tract, and now we're working into the cyst. Mouse. So the internal aspect of the cyst is pretty nasty looking. This is, sorry. This is all just an inflammatory wall, so this is a potential space normally not there. You can see it's pretty good size. If I could slide it forward to the business end, I would. You may just have to let it play out. So this is endoscopic debridement. Surgeons would do similar technique, but they would use Sharp's debridement. This is a little tripod device here that we use to grab a hold of necrotic material and pull it out. So by essentially devitalizing the cyst, by removing all this necrotic material, we try to cut down on the ongoing inflammation and risk of infection. The other thing that you can do is leave a long tube called a nasocystic drain inside here. It's curled up multiple times with little perforations in the tube, and then it comes out the patient's nose, and you lavage it out with sterile saline every couple hours for 24 hours, and that helps break it up. So this is all necrotic material here. It looks like pluff mud from the time I spent in Charleston, South Carolina. It smells horrible. These cases are extremely disgusting. You can see the patient's respirations. This is sitting underneath the diaphragm. The respirations really changed orientation. So I won't bore you because that was about a 2-hour case, but that, with more and more work, we got all that out eventually and got it looking pretty clean. And that patient went on to do very well. So let's talk about a case. All right, I need some participation with this. So this is a 53-year-old man with baseline hypertension requiring medication, hyperlipidemia, BPH. He comes into the ER in the morning with acute epigastric pain radiating to his back. Well, third-year medical student will tell you probably it's acute pancreatitis. He's got some tachycardia. His systolic blood pressure is 110. Normally it's much higher than that. Respiratory rate's 25, so he's tachypnic. He's got some mild hypoxemia on room air. You check labs, or the ER doc checks labs, and his lipase is 1250. The upper limit normal is 50, so clearly he's got acute pancreatitis. Hemoglobin 17, hematocrit 50%, appears heme concentrated. His creatinine is above baseline, it's 2.3. His total bilirubin is 2, AST is 250, ALT 300, alk phos 190. They're all up a little bit. They get a right upper quadrant ultrasound downstairs pretty quickly, and it shows some stones in the gallbladder, but no inflammation, no pericholecystic fluid or thickened wall. He's got a normal bile duct, so it's not dilated. They don't see a stone in the duct. And the overlying bile gas, as usual, obstructs good pancreatic views. So his pain's only slightly better after getting a couple milligrams of Dilaudid. He's been given some Phenergan and Zofran for his nausea, but the ER calls you because they can't send him home. He needs to be in the hospital. So what do? They call you, you're the admitting resident. What do you want to do? Does this guy need to go to the ICU? Does he need to go to the floor? What's the last part? Yeah. Yeah. So he may very well have severe acute pancreatitis, and the reason you say that's because he does have evidence of organ failure, right? He's got an acute kidney injury. He's got some hypoxemia. You know, from a cardiovascular standpoint, he is tachycardic and he's relatively hypotense and he's clearly heme concentrated. So all the bad things that you expect with acute pancreatitis, he's got a lot of these things going on. So they also get a CT. And this CT shows you normal pancreas enhancement with peripancreatic fluid collection. So again, he has local complications, no necrosis. So that by itself buys you moderately severe acute pancreatitis. But we know he's got organ failure. So this CT scan on this hospitalization really doesn't change our management. We already said he's going to the ICU. We already said he's got severe acute pancreatitis. And now that we've seen this, we're not changing any of that, right? So I did this on purpose just to show you that your imaging isn't necessarily helpful on admission. If he had necrosis, would it change your mind? Probably not. I mean, you know, infection on the presentation is extremely unusual. So all those inflammatory markers are part of SIRS, and he needs aggressive supportive care, not antibiotics, not any kind of intervention. So again, acute pancreatic fluid collection is what that's called. So you're right. You admit him to the ICU. You get good IV access. In this case, we started lactated ringers at 10 mLs per kilogram per hour. And as you watch him during the day, because you're the on-call resident in the unit for the day, the nurse is telling you he's urinating like gangbusters. His heart rate's already come down to 90, so that's good. His systolic blood pressure's back up to 130, so probably more like he's accustomed to. The respiratory rate is still a bit high, but it's coming down. At least it's not 18, so you know somebody's counting. And then the O2 sats are 94% on 2 liters nasal cannula. So not normal, but everything looks like he's doing a bit better. He's on a lot of pain and nausea medications, of course, and right now we have him NPO. Does that sound familiar? You guys okay with that? So day 2. So you come in, next morning it's your patient, your on-call colleague hands off the patient to you and explains what went on. Our vital signs are back to what we consider normal reference ranges. His pain's improved, but still present, and he's having a lot less nausea. You're really happy when you look at the morning labs and realize this guy's creatinine's already almost back down to his baseline. His total bilies come way down, so have the other enzymes, and his hemoglobin has approached back to what normal for him is. He's maintained good urine output, so we have 2 markers of good renal function, and he's still hanging out in the low 90s on 2 liters. His LR was continued, but during the day you guys, because he was doing so much better from a cardiovascular standpoint, decided to decrease the rate. And when you look at his net ins and outs, he's positive 5.5 liters over 24 hours. So what do you think is going on now? So this is day 2, so it's less than 48 hours. So is this is looking transient, persistent organ failure? Looking more like transient, I think, right? Kidneys are better. Cardiovascular is better. We got some O2 issues, but it's looking like he's responding to treatment. That's important. What are you going to do about his fluids? So you're taking over care today. What are you going to do? It's okay.
Yeah, so I didn't tell you. Let's say he's 100% on room air when he came in the ER. Okay. Okay. Good. So probably back off the fluid some, right? We're meeting our targets here. You can't be a machine and just keep them at this rate because this lecture said so or because the literature says that's what you do. It's all based on your targeted therapy. So we've achieved our goal in the case of his kidney function and his hemodynamic changes and his heme concentration. So I would argue that, yeah, I would put him on maintenance fluids, if anything, because he's still not eating, right? So day 3, the fluids were stopped like you mentioned the previous day. You get a chest x-ray, there's some mild pulmonary edema. He's tolerating clears. In my mind, when they tell you their pain's doing better and their nausea's better and they're actually hungry, that's usually a good sign to start feeding them. Start with something light, so clears is the way to go in advance as the patient tolerates. You transfer him out of the unit because he's no longer requiring close monitoring and observation. So he's now ambulating the hallway, which is important. IV narcotics were stopped. He's on PRN, moxicodone, 5 milligrams. So all of this is important. Mild pulmonary edema may or may not all explain his hypoxemia. Couple of things: pain, narcotics, sedating medications, Finnegan. All these things can contribute. So the quicker you try to reinstitute a normal status for him, the better you are. And with ambulating, you will redistribute fluid. So again, it's a distributive shock type process where throughout the SIRS syndrome, you've got third spacing. So a lot of the fluid you give is going to third space, including pulmonary edema. So the guy was discharged home the next day on day 4 with a diagnosis of moderately severe because it was transient organ failure. It wasn't persistent. And he underwent outpatient cholecystectomy 2 weeks later. Now, for mild acute pancreatitis, that's biliary in etiology, the recommendation is to have the cholecystectomy during the index hospitalization, okay? The reason why is these people get discharged and they don't follow up because they're feeling fine, or it's surgery's not until a month later, and they high incidence or high recurrence rate of their biliary pancreatitis or cholecystitis. So when you have local complications with fluid collections, though, you want to make sure on imaging those have resolved before you go in and do a cholecystectomy because it makes the surgery more complicated. And that's what happened in this case. They repeated the CT. So that's it. Any questions? You guys feel like here at the University Hospital you see a lot of acute pancreatitis on medicine, or is it most of the surgeons? Because when we're consulting, we're seeing a lot of it with the surgeons. Question?
We see it fair enough. I was wondering if you use the CT severity index.
Yeah, so in terms of severity scoring systems, there's a number of them, okay? And really you can't depend on one over all the others. So it has to do with ease of use. CT severity index is one of those. It's helpful, but again, because it's a very dynamic disease, depending on when you get the CT, it may not tell the story. And it's there's always the risk of radiation exposure and contrast. So to get repeated CTs is also difficult to do unless you have a change in clinical status, and then you really need to reimage the patient. Any other questions? Yeah. Yeah, so good question. Asymptomatic hyperlipasemia, that's an entity and can be caused by a number of things. But without pain, you have a high lipase, I always get imaging because, again, they could have evidence of radiographic findings of pancreatitis, and that patient needs attention. They need to have an etiology defined, okay, even though they don't have pain. So they may have CFTR mutations, may have divisome, there's a lot of things. But if they have a normal appearing pancreas, no symptoms, and just hyperlipasemia, it's likely not related to pancreatitis.
How high do the levels have to be? Or then 3 times?
Yeah, and I've seen patients where their elevations at times do get above 3 times the upper limit of normal, but other times it's less high. So I don't think you can be dogmatic about a cut point. Still, you have to have 2 of those 3 criteria: pain,
the lipase being high, and the radiographic appearance. So if they have a normal imaging and only that lipase, it's hard to know what to do with that, to be honest with you. Yeah. So take-home message for pancreatic pseudocysts. They're interesting when you find them, but take it in the context of your patient. If they're doing clinically very well, their weight's stable, they're gaining weight, they're not having symptoms with eating, just watch it. You can re-image them down the road in a few months, and the majority of these will resolve or go away. The ones that are getting bigger on interval scans, or the ones that are causing, space-occupying problems like gastric outlet obstructions, that's the low-hanging fruit. Those are the ones that you need to do something about, and a cystgastrostomy is a totally reasonable thing to do. Okay? All right, cool. Thanks.